Hello everyone, so this particular class will be on anticoagulants. So if you can still remember, it's actually a stronger form of blood thinning drugs compared to the earlier on, which is antiplatelets, right? So anticoagulants, you have a few different classes as well. So you can see the indications here, it's actually very specific because you actually use it for people who are actually at higher risk of forming blood clots. For example, people with atrial fibrillation, or people after surgery who can't move much, for example. So anticoagulants are very valuable, and also bear in mind the risk of bleeding is also much higher. So you can see there's a few of them over here, right? So there'll be more examples, as you can see, for the parental one, so i.e. most of them of anticoagulants, you actually need to deliver them with subcutaneous or IV form. So yes, subcutaneous, so they can actually do self-injection at home. But the thing is, there's traditionally only one oral medication, only one. But there's newer drugs, thank goodness, which are appearing as well. So which is much easier to predict the dose because there's not much interaction with other drugs and also with food. So first of all, let's go through the first one over here, which is the vitamin K antagonist. The name is called Warfarin, so make sure you open your eyes really big and really pay attention during dispensing, right? So this is the very valuable ones. Remember, this is the originally the only oral medication because again, everyone prefers to swallow a tablet for long term compared to you injecting yourself. Right, so warfarin, how does it work? So it basically acts indirectly. So remember, all the factors in the body is already existing, is already in the blood circulation, but needs to be activated. So there's non-functional prozymogens into functional zymogens. So the affected factors will be 1, 7, also 9 and 10. So remember, these are the common factors. So you can see that if you inhibit them, the effect will be pretty strong actually. So it requires this alpha glutamyl carboxylase enzyme, and but this enzyme, which is involved in the conversion into the active form of factors, requires vitamin K. So vitamin K is in a cycle. So you actually use reduced vitamin K, which then converts into oxidized vitamin K. Where does warfarin act? Which is acting on this vitamin K reductase, whereby it prevents the oxidized vitamin K to turn into reduced form again, and it's mainly by this S-warfarin, which is the more potent form. So you can see over here, based on the mechanism, it's not a direct inhibitor, so the full effect of warfarin actually needs to take a bit of time. Why? Because there will be a pool of activated factors already in the system, so you need to wait for them to degrade first before you can see a reduction in the new formation of factors, a new activation of factors. Right, so therefore the onset of time depending on the half-life of the clotting factors. So you can see the shortest one is factor 7, so therefore the effect takes about a day-ish. But the full effect will take even longer because you need to affect all the factors, remember? Right, so that's why mainly you actually need to use another anticoagulant, the IV form or the subcutaneous ones, to actually use as like a loading dose-ish kind of analogy, and then to convert them into warfarin before they're discharged. Right, so you normally don't use it for pregnant people. Oral bioavailability is pretty good, right? High protein binding, so you can see there's a lot of potential issues of interaction. And how do you adjust the dose of warfarin? So warfarin is available in tablet 1, 3 and 5 mg. They're in different colors. So but you cannot just say, oh, you use this dose. No, based on your weight or so on. It's actually based on something called INR. So details, please go and read up in BNF or your micromedex, right? So it actually tells you how you actually do INR. Basically, it's a blood test that the person needs to do, and it's mainly done by pharmacists. So if the person is on warfarin, you might be the one conducting the warfarin clinic, right? So from the INR, there's two main targets. It can be 2.5 or 3.5 depending on the indication, right? If they have artificial valves and things like that, so it'll be on 3.5 because the risk of having blood clot will be higher, right? So therefore, you have to adjust the dose based on the INR. But this is very tricky. Why? Warfarin, remember, is a long-term medication, right? And it has a lot of interactions. You can see with different drugs based on the cytochrome P450 profile. It can even interact with antibiotics because it limits the vitamin K absorption. So again, you enhance the warfarin effect, right? Because there's lesser vitamin K in a way, right? So, and also another thing is the vitamin K is also from food, specifically green vegetable. So from the green vegetable, obviously no one actually takes the same amount of green vegetables consistently over years. So we try to hit an average, right? But for some people, some days we are full vegetarian, sometimes we are overseas, we are outstation, we might not be able to eat salad or whatever green vegetable. Sometimes we just need to snack on Kentucky or whatever. So again, the dose will be quite tricky to adjust. So that's why it's very, very tricky. And remember, the tablets available in 1, 3, and 5 mg. So imagine if the person is at 2 mg, they might need to take 2 tablets of 1 mg. And in case you need an increase in the dose, you might say, or you might need to change your dose to 2.5. But if you change your dose to 2.5, then the person, you might give them a 5 mg tablet to cut the tablet to half. So it might be very confusing for the patient. So, and a lot of them are older people, so you might need to counsel the family members or the maid, the kakak and things, to make sure that there might be some older warfarin tablets at home. You don't double take it and things like that. So always check properly with them when you're dispensing. It's okay if you use a longer period of time, right? Okay, so for the second class that we look at mainly, still under, so it's unfractionated heparin. So for the first one, so there's issues about halal or not, so that's why we move on. So the dose is in units, it's in IV form. So again, something like warfarin, you need to measure INR. This one you have to measure something called APTT. So again, it's something that you need to monitor and so on. So if it's too much, you need to give an antidote. So it's called the protamine. So protamine, in a way, is basically, we'll look through in the next slide later on. So it can neutralize the effect of heparin, but heparin itself has more incidence or high risk of this thrombocytopenia, right? Because it's a foreign source. Right. So we have low molecular weight heparin. The more popular one is enoxaparin. So shorter one, less effect on thrombin, right? So it's more predictable response. You don't have to monitor, so it's much easier to dispense. It's a weight calculated dose. You can easier to use out of the hospital. A little bit of dose adjustment when required for those with very bad renal impairment people. So when you compare them, obviously it gets more specific. So low molecular weight is the enoxaparin that we're talking about. Fondaparinux is the name of the newer one, which is a shorter pentasaccharide. So there's no antidote for the newer ones, right? But it's safe to use in pregnancy. So when do we use them? So it's mainly for prevention. Prophylaxis is prevention, and also the treatment of thromboembolic diseases like DVT. So the patient cannot move so much after, like, for a hip surgery or knee surgery. So they'll be stagnant, lying down most of the time. Like, for example, like after C-section to give a baby, so that one they need to take it for a much shorter time, maybe 3 days, 5 days. But after a hip surgery, might need to take it over 2 weeks, right? So the injection to prevent DVT. So DVT is deep vein thrombosis, whereby there's a clot formed in the heart-ish, but the clot, when it travels down around the body, it gets stuck at the veins at the legs, so it can the legs become swollen, the blood flow is stopped, so it's called DVT. It's very dangerous actually. But pulmonary embolism is something more acute, so meaning the clot travel up to the pulmonary circulation. So therefore, these are situations that could be life-threatening, so you have to be very careful. Right, so therefore they're on anticoagulants, right? So about the protamine, which is the neutralizer-ish for heparin. So basically they act as a positive negative charge interaction, probably depending on the longer chain that the heparin has. Right, so therefore it can reverse the effect. So the last one that we look at, the shortest one, is the Fondaparinux. Okay, Fondaparinux is very specific, right? So it's a synthetic pentasaccharide. Again, all these are all for the same indication. So much predictable effect. So again, it's easier. So, but it's still in subcutaneous form. So therefore, the newer drugs that we like and we love is in oral form. So one of the example of the class is a direct factor 10 inhibitor. So inhibits the activated factor 10. So we've got examples of the drugs like rivaroxaban, apizaban, idozaban. So you can see the names in the middle, there's an X, so that's why it's factor 10. Sorry, a bit lame, but it's good because it does not require much monitoring. It's very fast, it doesn't have much interaction, right? Much faster than warfarin. Effect can kick in immediately. So some of the text rivaroxaban, for example. So again, for prevention, for stroke and DVT and things like that. So if they have AF, atrial fibrillation, or with one or more risk factor, even if it's just one, so you can see it's quite common to get if they're old and things like that. So they can be indicated for all these anticoagulants, right? And also bear in mind, if the studies, most of them show similar efficacy between warfarin and all this, but obviously the bleeding risk will be lower for all these newer drugs because the effect is more predictable, and obviously there's no interaction with the diet. So apizaban, some text over here, you can see it's quite similar, but this is in BD dosing, right? And you have other newer drugs like direct thrombin inhibitors, the factor 2 ones, right? So these are the some more older drugs, just to remind you the effects of factor 2. That's why if you inhibit it, the effect on the blood coagulation process is pretty strong, right? So these are the ones that actually inhibit to the catalytic side of the thrombin for this few, agratroban and lepirudin. So, but these are the very older drugs from Leech, as you can see here. So these are all the IV one, the subcutaneous one, bivalirudin, right? So you can see it can be used as an alternative to heparin if you need for some of the patients, right? But obviously what we love is the oral form, right? So moving on to the oral form, so we've got dabigatran, right? So this is direct thrombin inhibitor. So over here again, active in inhibiting the active form of factor 2. So it has all the same benefit as the factor 10 inhibitors as well, as listed over here. So minimal interaction with drugs, predictable pharmacokinetics, and so on and so forth. You don't need to monitor them so much. Right, so again, these are some text. You can see the indication are quite similar across all the drugs, right? So they realized that, again, as mentioned earlier on, so all these drugs, they have slight benefit over warfarin, so you can use them for those who has a lot of trouble in maintaining the dose of warfarin, right? But overall, obviously it produces lesser bleeding side effects, but it's not necessary to switch everyone to all these newer drugs, right? Okay, right, so there's some text again here about from the guidelines as well to see when you actually use anti-thrombin therapy, right? And don't forget there's the oral anticoagulants one, right? So you can see some of the duration of when, how long to use them, right? For in ST elevated MI situations, right? So you can use up to 8 days. Okay, so let's go on with the last class. Is the strongest among all. It's a thrombolytic agent. So basically you only use them when you know that confirm there is a blood clot. So basically you're putting a drug in, acts like a scissors to dissolve the clot. So you can see this is the strongest, so therefore it's very limited indication of when you need to use them, right? So you can see this is what mentioned in the first slide already. So plasminogen, you can activate it into plasmin, and plasmin therefore you work onto fibrin and then to cut down the fibrin, right? So whatever that you use is actually under here, tissue plasminogen activator, so you can actually activate over here, right? So again, main side effects very predictable. If the main one is bleeding, so obviously you've got nausea and side effects for vomiting for a little bit of them, right? So yes, this is where the tissue plasminogen activator work here, right? You put in over here. We are not talking about inhibitor, of course. So you can see there's again very indicated ones. You can only use it in ST elevated MI, nothing to do with non-ST, right? So again, some information over here. So you actually need to actually calculate the dose based on the body weight as well, right? So again, if it's more than 75 years old, you cut down the dose because it's very high risk of bleeding for them. So there's also very strict criteria on when you should not use fibrinolytic therapy because the risk of bleeding is way too high. So for example, there's already previous brain hemorrhage and things like that, or there's even stroke within the past 3 months and so on. So you actually need to check a lot of information before you actually use the drug on the patient. So you got a few of them. So the original one is streptokinase. So again, we're moving away-ish because again, this is the first version, and then we move on. So again, obviously all these drugs will be in IV form, right? Because it's the strongest, and you need something to have very short half-life, and you can easily reverse it if you, in case you give too much of it, right? So we got tissue plasminogen activator. So the good part of tissue plasminogen activator is that it mainly acts on the newly formed thrombi, because it mainly acts on the new one, so which is good because that is the one which you assume is problematic or is causing the disease or the symptoms that you see at that particular moment, because you want the other blood clots, which is mainly for other blood stopping the bleeding from other places, to remain there as well. So there's a few variants of tissue plasminogen activators. So thank goodness they all sound the same. It's all the place, alteplase, tenecteplase, and telretteplase, right? So all drugs, they're all equally effective, right? So alteplase is the recombinant, then the others are the generic. You can see the size goes shorter along the days, right? So sometimes you want it to be a bit longer, so it can be in OD form. Once it's stabilized, right, then it can give you a more normalized dose, right? So the tenecteplase in this case is better because it's more resistant to the plasminogen activator inhibitor, so therefore it can stay longer, right? So there's other drugs, again, these are not that popular. So this is an inhibitor for plasminogen, right? In case your scissors is too strong, so you can put in aprotinin, right? And there's also others as well, right? So again, it's not that much. So this is to promote clot stabilization. Right, so there's newer drugs, just to let you know, there are some possible newer drugs, like thrombin is actually activating on the PAR1 receptor. You can also give antagonists for that to actually reduce the blood clotting as well. So bear in mind, this is a slide to remind you how all the drugs actually come together for the treatment of MI or STEMI, right? So there's primary prevention, again, depending on which stage the person is, in terms of whether you need to use antiplatelets or anticoagulants, right? That's the two main ones. Or a combination of antiplatelets. So again, depends on which stage. If they're primary prevention, obviously you just use one. So most of the time it'll be aspirin, if it's not contraindicated. So again, if it's the more severe the situation is with a bigger plaque, so you need to top up with more drugs for a stronger protection for the patient, right? So again, this is the overall, right, of what happens. And remember, STEMI is something that you need to kick in very quickly in terms of your management effects, so that you can save the patient, right? So you can see details over here as well. Okay, so have fun, revise. See ya.